Hi, I'm Dr. Sloan from the University of Kentucky, and today we'll be discussing two important safety topics for the operating room, electrical and fire safety. APA content outline for electrical and fire safety. These are the key words which we'll be focusing on today. We will discuss sources of ignition, prevention of shock through different types of grounding and isolation transformers, macro and microshock, safety regulations set by the National Fire Protection Association, and risk factors for intraoperative fire. So, as we know, the modern operating room is full of electrical equipment, both surgical and anesthesia, wires, etc. This poses significant danger to both patients and providers. First, we'll go over a few basics for the physics of electricity. If you remember back from college physics, electricity is simply the flow of electrons. This flow is governed from Ohm's law, which states that voltage equals current times resistance. For electrons to flow, you need a closed circuit, i.e. continuous or uninterrupted flow, and a voltage differential to make the light bulb light. A circuit with a break in it is an open circuit in which electrons cannot flow, so the light bulb doesn't light. The last concept I'll mention will be very important later on when talking specifically about OR electricity. It's called stray capacitance. Capacitance is stored charge, and stray capacitance is unintended storage charge within a piece of electrical equipment, such as within a plugged-in power cord, even if the equipment is turned off. And again, we'll revisit that concept later on. So why is electrical safety important in the operating room? We're trying to prevent electrical shock from occurring, either to the patient or the provider. Electrical shock occurs when a person becomes part of the electrical circuit. It requires 2 points of contact so that a complete circuit is formed, and a voltage source, which is the power. So as you can see, this person has become part of the electrical circuit, which has a voltage, so the person would sustain a shock. Electrical shock can cause injury in two different ways. One, it can directly disrupt cellular function by disrupting cell membranes. For example, electricity interfering with cardiac myocytes, electrical signaling could cause a cardiac arrhythmia. Secondly, it can cause injury from the dissipation of the electrical energy, which is turned into heat, which can then cause burns. When we talk about electrical shock, there are two types, macro and microshock. The difference is the amount of current. Macroshock is caused by large amounts of currents that can cause injury or death for anyone through the skin. This chart gives you an example of different amounts of shock. 1 milliamp is the lowest point where we can perceive a shock, up to 10 milliamps where you would be unable to let go due to sustained muscle contraction. 100 milliamps will cause ventricular fibrillation. Microshock, on the other hand, is caused by very small amounts of electrical current that can cause injury due to direct contact with the heart, i.e. a pacing wire PA catheter into the heart. For example, it takes 100 milliamps, we said, for VFib to occur by macroshock, compared to only 100 microamps for VFib to occur through microshock. So how do we prevent electrical shock? Grounding. There are two different types of grounding. One is the grounding of electrical power, and the other is grounding of electrical equipment. There is a difference between grounding in a home versus in an operating room. In the home, our power is grounded, and equipment may or may not be grounded. Conversely, in the operating room, the power is ungrounded, but the equipment is grounded. In a typical home, electricity comes from the power company through the hot or the live wire and is grounded through the earth. This is grounded power. So if there is a fault, which is an accidental connection between a source of electricity and the electrical ground, i.e. a short circuit in your house, and you touch it, you become part of the circuit because you have 2 points of contact, the faulty equipment and the ground, because the ground is part of the circuit. And there's a voltage source from the power company, so you become part of the circuit. There is a voltage source, and so you are shocked. It is important to note that in grounded power, you only need one fault to cause macroshock. Conversely, an operating room has ungrounded power. This means that the electrical circuit is isolated from the ground. This requires an isolation transformer to convert the grounded power from the power company to ungrounded power in the operating room. This is called an isolated power system, or IPS. Again, meaning it is isolated from the ground. So if you touch one of the lines, you are not shocked because the circuit is not complete. The ground isn't part of the circuit, so no shock would occur. However, if you were to touch both of the lines, then shock would occur. The benefit of an ungrounded power in the operating room is now that it requires two faults to deliver a shock, thus helping prevent macroshock. The first fault converts the isolated power system from an ungrounded to a grounded power system, like a home, and then the second fault would then result in a macroshock. The isolated power system in the previous slide assumes perfect isolation. However, like I mentioned at the beginning, there's a phenomenon called stray capacitance, which exists. This means that within all the electrical equipment in the operating room, there is stored up charge that can leak current to the ground, which partially ungrounds the isolated power system and creates the potential for macroshock. Because if the power system is now grounded, only one fault is needed to cause a shock. The line isolation monitor monitors this leakage of current and thus the integrity of the isolated power system. It looks like this little box on the wall in the operating room. It gives the potential current in the event of a fault. This is the potential shock which could occur. So the line isolation monitors for the presence of an initial fault, and the goal is to correct this before a second fault could occur, which will result in a macroshock. This line isolation monitor can be set to 2 milliamps or more modern systems 5 milliamps. So this shows an example of plugging in a faulty piece of equipment which grounds the power, which will be detected by the line isolation monitor. The alarm will sound, but again, it does not indicate that any shock has actually occurred. So, what to do if a line isolation monitor alarms? The goal is to correct whatever the first fault was, which grounded the system. One cause can be too many pieces of equipment plugged in. All the equipment has some stray capacitance, which is additive, so too much equipment could trigger the alarm. Another cause could be a faulty piece of equipment, like in the previous example. So the first thing to do is to unplug the last device that was plugged in until the faulty one can be found and sent for repairs. However, remember, you can continue to use the equipment if it is life-saving. So, for example, if you're on cardiopulmonary bypass, you can leave the machine plugged in even if the line isolation monitor is alarming. Again, the line isolation monitor does not indicate that anyone's being shocked, just the potential for shock. But remember, if you do keep using the equipment with the line isolation monitor alarming, the isolation power system is no longer protective. So we talked about ungrounded power in the operating room, helping prevent against macroshock. The other form of grounding is grounding of electrical equipment to prevent macroshock. Hospital plugs have 3 prongs, one of which, the longest one, which is shown by the arrow, is the ground, which helps prevent macroshock. In the event of faulty equipment, the majority of the current should flow through the low resistance into the ground wire. Thus, if you have broken wire or plug, that's a potential for danger. That's why hospital-grade plugs are supposed to be easy to inspect like this, clear or easy to disassemble so they can be inspected. And these hospital plugs over here show you, again, that the ground wire should always be intact and is the one that should be inserted first into the electrical outlet. So what if you have a grounded power system like a home? How can you prevent macroshock? So ground fault circuit interrupters can be used. These are often used in wet environments which have a higher risk of shock, like bathrooms and kitchens in homes. If faulty equipment is plugged in, the GFCI will trip and the circuit will be interrupted. This will shut off the power and the equipment will be non-functional. For example, if you've ever had a hairdryer short circuit and trip and then turn off. This prevents against shock because there is no power to the device or the circuit, and thus there is no circuit. However, as you can imagine, in an operating room, this could be problematic. So now we've talked about macroshock prevention. So how do we prevent microshock? So this picture shows how a faulty ground wire could cause current directly into the heart that could cause ventricular fibrillation. Without the ground wire, the equipment is leaking about 100 microamps of current, which is too small to cause macroshock. However, if this were directly routed into the patient's heart through a wire such as a pacing wire, a PA catheter, directly into the heart, this could cause VFib. To prevent this, we try to isolate the patient. We try to isolate the patient from monitors by having very high impedance, for example, the EKG circuits. We try to isolate ourselves from any electrical devices, wear gloves when touching anything that's going directly into the heart, and of course keep external currents like nerve stimulators away from any wires that are entering the patient's heart. And again, an intact ground wire is very important for preventing microshock by directing these leakage currents through the ground wire instead of through the patient. So now we've talked about the dangers of electricity, but there's also dangers inherent to power failure in the operating room. It's important to make sure your operating rooms have contingency plans in the event of a power failure. A key is a light source, a battery-operated light source for all the operating rooms. It's important to know exactly what your anesthesia machine battery will supply and how long it will last. Finally, it's important to know about your hospital's emergency power supply, i.e. generators, and importantly, know that red hospital plugs are the ones that are functional in the event of generator use. So important equipment should always be plugged into red outlets, so in the event of a power failure, those will continue to function once the generator kicks on. The National Fire Protection Association standards are one of the ABA keywords on the content outline. So what are they? Specifically, the NFPA 99 standards are healthcare facilities code standards that establish guidelines for any healthcare building to protect the building, the patients, providers from fire, electrical hazard, other hazards. It includes electrical, plumbing, HVAC, gas, vacuum systems, etc. So why do we need to know about these? Historically, due to flammable anesthetics, all operating rooms were required to have an isolated power system for safety. However, due to newer non-flammable anesthetics, this was then considered non-essential. Anesthesiologists did not think this was the safest system for the operating room. So now operating rooms are classified as wet procedure locations, which means that they have an increased risk for electrical shock. Thus, ORs, according to these standards, need to be protected by an isolated power system or ground fault circuit interrupters. In order to be exempt from this requirement, a risk assessment has to be performed to classify an operating room as a dry location, which does then not require these electrical safety precautions. Thus, it's very important for anesthesiologists to know the state of your operating rooms and to be involved with the planning and construction or renovation of operating rooms. So we've covered electrical safety, which is an inherent danger to the operating room because it's always present. Now we're going to talk about fire safety in the OR. Fire should obviously not be normally present in the OR. However, there is always a risk of fire in the OR, so it's very important for anesthesiologists to understand both the risks and prevention of operating room fires and, of course, management in the event of one. So first we'll discuss the risk factors for an OR fire. This is called the fire triangle. Basically, it shows what is necessary to have a fire: fuel, ignition, and an oxidizer. Fuel is something to catch fires, such as alcohol skin preps, drapes, hair, basically anything flammable. Ignition is something to start the fire, such as electrocautery, laser, fiber optic light, anything that can spark. And finally, oxidizers are needed to maintain the fire, and these are oxygen and nitrous oxide. Anesthesia Patient Safety Foundation has a number of useful resources for OR fire safety, including this OR fire prevention algorithm, which goes through ways to reduce the risk of an OR fire. This is important for everyone in the OR to understand: anesthesia, surgery, nursing, and to be aware of, and it should be part of the timeout, particularly for high-risk procedures. First, is the patient at high risk for surgical fire? So this would be head, neck, upper chest procedures using an ignition source close to an oxidizer. So basically, any head and neck procedure using cautery with the patient on oxygen. Most commonly, these are MAC cases with a nasal cannula or face mask. If no, proceed, but reassess risk as necessary. If yes, the procedure is a high fire risk, make sure to allow the skin prep to dry and communicate between the surgeon and the anesthesiologist before any electrocautery is used. Next, does the patient require supplemental oxygen? If no, use room air only. If yes, does the patient need greater than 30% FiO2? Why 30%? Because over 30% FiO2, basically anything can be fuel for a fire. If no, then use less than 30% FiO2. If yes, then the airway should be secured with either an endotracheal tube or an LMA. This contains the oxygen, which is the oxidizer within the circuit, to make it what's called a closed system to try and minimize risk, compared to nasal cannula or face mask, which is an open system, which increases the risk. Again, this algorithm is something that you should be thinking through for every case. So let's say, despite all your careful prevention strategies in the last slide, you have an OR fire. This ASA algorithm goes through how to manage it. First is an airway or non-airway fire. For an airway fire, immediately remove the endotracheal tube and stop the flow of all airway gases. Then pour saline into the airway. Next, you want to reestablish ventilation, bag mask ventilation. Avoid high FiO2 if possible. Examine the tube to see if there's any pieces that seem to be missing. And finally, consider bronchoscopy, particularly if you think part of the ET tube is missing, to look for it in the airway and also potentially to assess for any airway damage. For a non-airway fire, immediately, again, stop the flow of all airway gases, remove the burning and flammable materials, and extinguish the fire with saline. Next, maintain ventilation. If the patient's not intubated, assess for inhalation injury or the possibility for inhalation injury. If the fire is not extinguished on the first attempt with saline or water, then you can use a fire extinguisher, even if it's on the patient. If the fire extinguisher doesn't work, then activate the fire alarm, evacuate the patient. You want to close the operating room door and turn off the gas supply to the entire OR. So again, very important for both airway and non-airway fires is the first thing is to stop the flow of all airway gases, because you're trying to stop the source of the oxidizer, and then extinguish the fire. Here are my references for further reading, and thank you, and be safe.